morning, everyone. I'm
Good morning.
interns, and today we're going to be talking about the initial mechanical ventilation in the emergency department. On a side note, I was supposed to give this during the home conference week, but it got delayed and rescheduled, so I had to throw a little bit of COVID in it. So hopefully it's going to be a good refresher for our memories when taking care of the patients that are put on a vent machine. So as all of you guys know, we have two strategies after putting a patient on a ventilator. We have the lung protective strategy and we have the obstructive strategy. And the lung protective strategies, the recommendations were based on the ARDS-NET protocol. And these are a group of studies, a group of RCTs. One of them is called the ARMA study, which basically compared a group of ventilated patients on a low tidal volume versus a group on a traditional tidal volume. By a low tidal volume, they were giving 6 ml per kg, and with a traditional tidal volume, they were giving 12 ml per kg. And they found that there's significant reduction in morbidity and mortality in the people that receive a lower tidal volume. They also have a couple of other recommendations, which we're going to go through briefly. They emphasized on a higher PEEP in moderate to severe ARDS. And in general, any patients that's intubated in the ED, we're going to go with the lung protective strategy, regardless of the cause of the intubation. On the other hand, we have our obstructive strategy, and we mainly use this strategy in patients that are asthmatic, COPD patients who have some pathological narrowing in their airways. And the goal here in this strategy is to give, their problem here is they have a prolonged expiratory time. So we're going to go with a strategy, we're going to consider their prolonged expiratory time by giving less respirations per minute, and that is to prevent air trapping and barotrauma and something called intrinsic PEEP. We're going to go through a brief case regarding every strategy. First, we have case number 1. Here's our 65-year-old gentleman. He's complaining of shortness of breath. He looks lethargic. The family member tells you he has been short of breath for the last 2 days. So, what do you want to know about this patient?
Fever.
He has no fevers. I still didn't throw it in right now. So this patient has a past medical history of hypertension, COPD. He has a 30-pack year smoking history. He was admitted last month due to a COPD exacerbation. On examination, he's altered. He looks lethargic. He's not answering questions properly, and he has diffuse bilateral expiratory wheezes with moderate air movement. Vital signs: his temperature is 99, his heart rate is 109, his blood pressure is 168 systolic, and he's tachypneic with a respiratory rate of 32 and satting 86% on CPAP. So the question is, do you want to intubate this patient? So obviously, do you want to intubate this patient?
Yes.
Yes. Okay. So regarding this is a patient who we're going to go with, through the obstructive strategy. And the best thing that we do for these patients is try to not intubate these patients. They respond well to aggressive pharmacological management, non-invasive ventilation. So the best strategy in obstructive patient is not to intubate at all. But if the patient's lethargic, he's not maintaining well, then we're going to proceed with intubation. There's a score that I found in MedCalc. It's not the best score, but it's basically what we do in our clinical practice. It's called the BAP 65 score. And it basically just adds a BUN more than 25, altered level of consciousness, a pulse more than 109, and an age more than 65. And it's somewhat similar to what we do in our clinical practice without even needing a scoring system. So we decided to intubate this patient. We are prepared. We have all our equipment, all our IV sedations, and we called the respiratory therapist. So we proceeded with intubation. We passed the tube, and we hooked the patient to the ventilator. 20 minutes later, we get this ABG. So this is the post-intubation blood gas, showed a pH of 7.1, PCO2 of 98, and a partial pressure of oxygen of 95. So clearly the patient is acidotic. How are we going to fix this acidosis? Any suggestions?
Increase the rate.
Increase the rate. Perfect, Chief. So there's 5 pieces of information that a respiratory therapist wants to know. He wants to know what's the mode of the ventilation. He wants to know the tidal volumes, the respiratory rate, the PEEP, and the FiO2. Going briefly through each one of them, this is our lovely ventilators, the ventilation machine that hopefully we don't run out of. So basically, the modes of ventilation. The mode of ventilation, it basically describes how the ventilator controls the pressure, the flow, and the volume of each breath, alongside with the description of how the breaths are sequenced. And we have something called the volume assist control, which is the most common vent setting that we use in the ED, and it's our go-to mode in the emergency department. So the volume assist control mode, the key here is that the machine is gonna give an exact amount of flow per unit of time. So you're gonna preset the machine with a tidal volume. Let's say you put the tidal volume on 500, and you're also gonna preset the machine on a respiratory rate. Let's say you put it on 12. So the machine is gonna guarantee 500 cc of flow each 5 seconds, regardless of the pressure in the system. But so the machine senses a negative pressure in the patient. The patient expands his lungs, he triggers the breath. It's gonna sense a negative pressure, and according to that negative pressure, it's gonna give its 500 cc, regardless of the pressure in the system. So it's a compliance dependent. If the compliance goes low and the patient has an increase in his pressure, the system will give you an alarm. In contrast to the pressure support or the pressure control system, which basically guarantees a pressure per unit of time. Here, the flow is not the same in every cycle. It's compliance dependent. So if the patient has a good compliance, the volume, it will give the desired volume. If the patient's compliance is low, the volume is gonna go low according to the patient's pressure. We also have something called a CPAP mode. There's a lot of other modes that are definitely, they have more details, but we have something called the CPAP mode, and it's somewhat similar to the CPAP mode in a non-invasive ventilation, and it basically gives a continuous positive airway pressure and ensures that there's some pressure on the end of expiration to prevent alveolar collapse and more recruitments of alveoli. So the tidal volume, so that's the mode. The tidal volume is basically for alveolar protection, and it's based on the predicted body weight using the height of the patient. As in our case, the way that we fixed his acid-base status by increasing the respiratory rate and obstructive.
I think you got to do some other things before you change the respiratory rate. First of all, this is not an emergency. Permissive hypercapnia is a well-established ventilatory method. And you'd like to get the pH above 7.2, that's okay. This is pretty close. So I think what you have to do is check a few things.
Mm-hmm.
What's the chest x-ray look like? Where's the ET2, right? Is it in the main stem bronchus?
For sure.
And you're getting high pressures? I think you have to troubleshoot a little bit before you just react and change the respiratory rate the minute ventilation change the PCO2. Is there an NG tube and the stomach is decompressed? Sometimes after intubation, there's a large air bubble and it decreases diaphragmatic movement, so patients, don't have the right tidal volume. Is the machine getting the tidal volume back? Is there a leak in the system? Is the balloon up or the balloon down? Is the pressure in the balloon correct? Is there a pneumothorax? Right?
Mm-hmm.
So I think before you do that, is the patient over-breathing the machine? Is the patient alert and over-breathing the machine? Is the patient having air traffic? So one of the things I do is I get a chest x-ray. Before I change any of the ventilator settings, I check the balloon, I check the circuit, I check the machine to see if the volume is coming back. I get a chest x-ray. Changing the respiratory rate is like the last thing I do.
Okay.
So I would troubleshoot the patient, the ventilator, and the tube before I would change the respiratory rate.
Okay.
So I think you have to do those things. And how much to change the respiratory rate? Are you going to go over?
I'm not going to go over, but I'm
So
going to go
gotta
over
change-
these points by the end of my presentation about there's a deterioration of intubation. But if you want to add about how I'm not going to change the respiratory rate, I'm not going to go through
It's just the minute ventilation times the PCO2 you have equals the new minute ventilation times the PCO2 you want. It's linear. So you just have to divide, and if you change if you keep the tidal volume the same, it's the respiratory rate times the PCO2 you have equals the new respiratory rate times the new PCO2 you want. And I wouldn't change it if everything works out and you wanted to change the PCO2, I would change it a small amount to get the pH above 7.2. Maybe 10 millimeters of mercury change in the PCO2. So from, it was like 100 to bring them down to 85 or 90. There's no reason to try to chase the PCO2. In fact, you lose the
drive.
benefit of the obstructive pattern which you want on the PCO2. So there are other things you can do if was he hypoxic? Do I have to play with the PEEP? Do I have to play with the rate that the air goes in, right? Because the idea is to prevent air trapping, to have the longest expiratory phase you want, right?
Exactly.
So you can change the inspiratory force, how fast the air goes in. You can change the rate, right? And you can change the PEEP. All these things affect the expiratory phase. I'm sorry.
Oh, thank you. Thank you so much. So, as Dr. Sinner mentioned, so the PEEP and FiO2 are for titration of oxygenation. But just to bear in mind, if the FiO2 is greater than 50%, any continued hypoxemia is due to physiological shunting. So the PEEP and FiO2 always work in tandem. Just be cautious when you go downwards with your FiO2 and PEEP, because going downwards fast may cause loss of recruited alveoli. So here's our second case. She's a 70-year-old female, possible history of diabetes, hypertension. She presented with a 5-day history of fever, non-productive cough, progressive worsening of shortness of breath, malaise, and decreased appetite. This is a patient that we're seeing a lot these days. She's tested COVID positive. She has a temperature of 101, a heart rate of 89, and a BP of 140 with a low saturation. Here's a couple of x-rays that we're seeing nowadays. And as you guys can see, the peripheral consolidations, the basilar consolidations here in the patients with COVID-19. I just wanted to thank the people that wrote this blog, Noah, Andrea, Suvam, and Julian. I'm just going to read a paragraph that they wrote. So our institutions are supporting early intubations and avoiding of non-invasive positive pressure ventilation, high flow nasal cannulas. Vent settings for patients in ARDS should follow the ARDS net protocol with a tidal volume of 4 to 8 cc per kg with fluid restrictions. They also recommend proning of the patients and in severe ARDS. The most critically ill patients might require an ECMO. However, 83% of these patients may still die. One thing that is important to remember is utilization of resources. So this is just a brief about the difference between the numbers between the lung protective strategy and the obstructive strategy. We see lower respiratory rates in the obstructive strategy, a higher PEEP in the lung protective strategy, and how the PEEP and FiO2 work in tandem. Lastly, if the patient got deteriorated after post-intubation, first thing to look before bumping the respiratory rate is look for any displacement of the ET tube, any obstructions along the pathway. Make sure you suction the tube for any mucus plugs, any pneumothorax. Make sure that you get your x-rays and any signs of equipment failure. And S stands for stop, press, or auto PEEP. And this is something that we see in an obstructive lung pathology where we give a high flow in these patients, causing them to an increase in their auto PEEP, and they get this drastic decrease in their blood pressure and hemodynamic instability. So the immediate thing to do in such patients is disconnect from the ventilator and try to apply physical pressure on their chest to remove all the airways. This is a cheat sheet from the ARDS net protocol, which shows the inclusion criteria for ARDS, the ventilator setups, and the oxygenation goal of 55 to 80, and the SpO2 of 88 to 95, and a plateau pressure goal of 30 centimeters of water. Thank you, Dr. Tan and Dr. Solarose, and here are my references. So thank you, everyone. Any questions?
Let me see if there's any questions or comments from
Flores has a question. Go ahead and unmute yourself, Flores.
Flores.
No?
I can't see if anyone is writing anything. I only see Dr. G.
Hey, can you hear me?
Yeah, hold on. I'm trying. Okay, go ahead. What was your question?
Hey, no, just wondering why you were focusing initially on the respiratory rate for the obstructive strategy for this patient, because for patients with COPD and asthma, we're trying to avoid auto PEEP and having a low respiratory rate. So for those patients, I would probably start off initially by increasing tidal volume.
Right. So that was,
Okay, I heard your question, Brian, and it's the same point. So he was talking about the same point that Dr. Sinner was referencing about why did you concentrate on the respiratory rate instead of looking at all the other measures. I think Dr. Sinner gave a good comment about that. So definitely before pumping the respiratory rate, we're going to see if there's any problem in the tube, if there's any problems in the circuit, and then there's I forgot it, but it's basically an algorithm for the desired PO2 versus what our goal PO2 is, and then based on that we can decide what respiratory rate we want. So if you were here, you would know. Any other questions?
Just one thing, sometimes before these patients, before I use them on BiPAP, they're looking pretty tight and severe. I actually do a manual HUD, believe it or not, like a squeeze, especially if they're able to exhale. Kind of do a little bit of manual decompression as well. And there's been a couple of patients the past few months during flu season that I was able to sort of do that, and they like look significantly better actually as soon as you do it, even before the respiratory therapist gets down to put them on BiPAP. There's a couple of young people who had asthma and flu. So I don't know if it's really been studied, but I was always taught that by my attendings when I was a resident. And I think it's just something that can sometimes help a little bit to just try to decrease some of that auto PEEP that they probably have even before they're on the
manual.
like this. I just actually hug them from the side. I wrap my hand around their back. I squeeze
wrestling
them side to
hug?
side, a little pressure on the chest, and I ask them to exhale as long as they can. And while they're doing that, I just physically squeeze their chest kind of from the side and from the front. It just kind of gets a little bit more air out. And a lot of times you'll actually see them take visibly deeper, better breaths. I don't think it works very well if they're really panic breathing and they can't exhale while you're doing it. And once again, I don't know if it's really been studied, but I've been shown that by a number of attendings throughout residency. And each time I've seen it done, it's really, it usually helps, at least a little bit.
Have you seen that more for asthmatics or
No, for both, asthmatic and COPD. I think it actually works better for COPD patients, but the past couple during flu season were asthmatic patients that I noticed like instant improvement in their, just visibly, the physical exam and how they were breathing, how they were moving air, and just even how much they were pulling.